clinical examination considerations for patients with non-arthritic hip joint pain. This video briefly discusses applying the clinical practice guideline recommendations in terms of evaluation for patients with non-arthritic hip joint pain. My name is Keelan Enseki from the University of Pittsburgh Center for Sports Medicine and Rehabilitation Institute, and representing the Academy of Orthopedic Physical Therapy, one of the authors on the current rendition of the hip pain and movement dysfunction associated with non-arthritic hip joint pain revision clinical practice guideline. It's helpful to have a brief overview of the history of clinical practice guideline development. In 2006, the AOPT started an initiative to use the ICF, or International Classification of Functioning Disability, to develop evidence-based practice guidelines to guide clinicians and physical therapists' management of common disorders. And we looked at the domains of diagnosis, interventions, prognosis, and assessment of outcomes. The ICF is a disablement model that was developed by the World Health Organization in 2001. Looks at function and disability and classified in terms of body structure and function, and also in terms of activity and participation of patients. Some additional details regarding the methodology that are pertinent to this particular CPG. We performed a formal literature search for evidence related to examination and rehabilitation intervention in individuals greater or 13 years or older who had non-arthritic hip joint pain diagnoses. We also did a scoping review and provided descriptions within the CPG pertinent to a pathoanatomy, differential diagnosis, and the clinical course. Level of evidence were assigned to the formal literature search results that were appropriate. You can see 1 through 5, 1 being the strongest evidence, high-quality diagnostic studies, prospective studies, systematic reviews, randomized controlled trials, all the way down to expert opinion is level 5. Grades and recommendations were then produced based on the levels of evidence from our search. And you can see it's A through F. This is, some people may view this as a report card, but it's important to note how you interpret these recommendations. A is the strongest, based on the strength of evidence. F is expert opinion. It would be our weakest recommendation for any recommendations that were made. Note that D is conflicting evidence, that studies disagreed on the particular topic. And then in more recent CPGs, including this one, levels of obligation were assigned. So a must or should for the strongest of recommendations, all the way down to a may for those recommendations that were weaker. Additional history about this particular clinical practice guideline for non-arthritic hip joint pain. The initial CPG was published in 2014 based on a fairly limited body of evidence at that time. The most recent publication is 2023 in the Journal of Orthopedic and Sports Physical Therapy, and it represents an expansion of available literature pertinent to rehabilitation for these individuals. This video will discuss within clinical evaluation the recommendations from the most current CPG. The 2014, you can see a summary here of the 2014 CPG based on limited evidence, so it should be of no surprise that it's a fairly small number of recommendations, and most of us received an F level, so expert opinion, that's all we had at that time, recommendations for both evaluation and intervention within the domain of physical therapist management for non-arthritic hip joint pain. Now to the 2023 publication. You can see an expanded number of recommendations. Overall, a stronger evidence to support or better evidence to support our recommendations. So they received a stronger recommendation level. Again, in this particular video, we will focus on diagnosis and examination, but it is important to note though we're not covering them, we did make recommendations for interventions as well. Also, important to note, what is non-arthritic hip joint pain? Non-arthritic hip joint pain refers to a number of intra-articular sources of hip pain that result from one or more of the following conditions. Far and away in the literature, you'll see femoral acetabular impingement syndrome, and we'll discuss that term. Many people just know it as FAI, but FAIS. Development dysplasia of the hip, acetabular dysplasia, hip instability, which is really a multifactorial entity and can include a number of these other terms within, and we'll discuss. resulting acetabular labral tears, osteochondral lesions, loose bodies, and more recently ligamentum teres tears. Again, many different potential diagnoses. Of course, none of them qualify as osteoarthritis. There's a separate CPG that is currently in revision that will look at that diagnosis. So again, non-arthritic hip joint pain. The greatest amount of literature available is currently looking at FAI or FAIS, excuse me, femoral acetabular impingement syndrome. We noted dysplasia as shown here, acetabular dysplasia, ligamentum teres involvement more recently discussed, and we do capture some recommendations and discussion within the current CPG, and the often resulting issues of acetabular labral tear and chondral damage as well. Coming back to femoral acetabular impingement syndrome, FAI is probably the most common term you will see, and it's important that we make some differentiations here. FAI, femoral acetabular impingement, is an anatomical variation of the hip joint that can occur either at the femoral head neck junction, the acetabulum, or a combination of both. When you have an increased bone presence at the head neck junction, the term that you'll see in the literature is CAM FAI, as shown in the upper right-hand corner. It increases the offset of the femoral head neck junction. Pincer FAI it's a term that represents acetabular involvement. Now, this could be via increased socket depth, so a deep acetabular socket, you'll hear the term cox profunda, or a retroverted acetabulum. The net result of either, or a combination of both, will be increased coverage of the femoral head by that socket, by the acetabulum. Clinically, what we often see is a mixed presentation. It's common to see some combination of both CAM and pincer impingement. Again, up to this point, we're only discussing anatomical variation, not necessarily pathological in all individuals. Which brings us to an updated term, femoral acetabular impingement syndrome, so we add an S. This term stems from the Warwick Agreement, a publication in 2016 by Griffith and colleagues that introduced the term to expand upon just the anatomy. So to look at a diagnosis that was based on anatomy, as just discussed, the various forms of impingement, symptomatic presentation, movement quality or deficits. So we have a more encompassing term, anatomy plus clinical findings, to come up with this term of femoral acetabular impingement syndrome. It also expands and gives us a better ability to discuss the treatment options that are available. So it's not just anatomy we are addressing, but more the whole complete presentation in front of you, the patient presentation. Hip dysplasia is another term that encompasses a number of anatomical variations. Right? So very often you'll hear the term developmental dysplasia of the hip, DDH. It's often used to describe those morphological variations of the acetabulum that present after or around pediatric patient, after birth or around pediatric patient's development. We speak to it as a condition in the CPG, but for the most part, we do not discuss in much detail what evaluation or intervention. Remember, our literature search encompasses individuals who are 13 years or older, but it is always an important part of the history if it is part of that patient's past. Acetabular dysplasia describes changes in the normal orientation that could be direction or version, or in the shape, inclination, or depth of the acetabulum. Okay, we do speak to this to greater extent in the CPG and its potential role in patient presentation. Of course, there are numerous variations of the femoral head, such as a flattened femoral head, just one example, that can exist. And though not speaking to as much detail, they're less common in the CPG. We must realize that that also qualifies as hip dysplasia. Shown in this image, it's an actual patient, is a patient with acetabular dysplasia. It's actually a preoperative CT. And what you can see here is the femoral head is notably uncovered in the front due to an anteriorly oriented or an inverted acetabular socket. And then the term hip instability. Again, it's important to remember instability is a multifactorial entity, right? There's an anatomical component in many, maybe most cases, but that isn't the only consideration. We have an anatomical component, there's patient presentation, right? Symptoms, functional limitations, etc. Instability can be caused can have numerous causes. It can be iatrogenic. Okay, it can be actually caused by surgery in some cases or other medical procedures. Connective tissue disorders. People are predisposed to instability with or without bony abnormalities. Bony abnormalities is what we have discussed. Now we've just discussed dysplasia, but it's known that in the hip, there's a substantial amount of there's a substantial presence at times of FAI characteristics in individuals with instability. So it's important to note that they are not separate all the time. It can be acquired from repetitive sport activity that passively overloads, if you will, the soft tissue restraints of the hip, post-traumatic, and idiopathic at times we don't know. But it's important to note any combination of these particular components that contribute to the clinical presentation of instability may be present. And it's important in evaluation specifically. This is taken from the current CPG, as referenced below. That's important to note, particularly in the direct access setting, but really in any setting, that we may have to determine whether this individual, even though they're presenting with hip pain, actually is having pain that is appropriate for us to treat within physical therapist management. We don't speak to that much in this particular video because for time constraints, but we are not ignoring that. However, if we determine that this is an individual that is appropriate physical therapist management, we then look at classifying the condition. We'll speak to that through patient examination, differential diagnosis. Is this truly a non-arthritic hip joint pain condition that we're looking at? Or is it a different condition? Or very commonly, overlapping conditions, which helps prioritize how we will evaluate and treat this individual. And then, how is this individual affected by the condition? Our patient-reported outcome measures, physical impairment measures should go without saying, activity limitations and participation, what does their movement quality look like, if you will. And we'll speak more to that in this fairly brief video regarding the findings of our CPG and our recommendations. In regard to special tests to help qualify a condition, what we do know, and we give a C-level recommendation, C meaning it is, it is not the strongest of evidence, fairly weak evidence, but it's better than we had in the 2014 a rendition of the CPG. And again, it's neither good nor bad, right? It just tells us where we are in terms of the strength of evidence and the recommendation we can make based upon that evidence. Two common tests that we'll see, the Fadir test, the Faber test. The literature overall tells us they're better for screening, right? Negative test result may be more useful than a positive one due to overall better sensitivity. But you will see the Fadir test as shown in the upper right, where the patient is passively flexed, adducted, internally rotated, and we're looking for reproduction of that patient's primary pain and the symptom that represents joint pain involvement, right? It's always important to ask, is this why you're here to see me for the most part? And where does the pain occur with this particular maneuver? Both this and the Faber, for the most part, we're looking for symptom provocation. The Faber test in the lower right, again, a better screening tool, at least in regard to what the literature says, versus having specificity for a condition. But it's a common test that we see. It's been taught for many years across the board for different conditions, not just for the hip, but even including the SI joint involvement. So again, it's important to note, we place that person into flexion, abduction, external rotation. Second part of the test can be application of overpressure. It can and has been described as looking at just general mobility. But in terms of symptom provocation, again, we do have to make sure that if they tell us that it is uncomfortable, where do they report the symptom to occur? Does it match their primary symptom? Does it represent hip joint pain? Okay. Again, overall, these tests are more useful for screening due to their better sensitivity overall, if you look at pooled sensitivity in the literature. We were able to make a recommendation, this is new, was not in the 2014 CPG, for ligamentum teres testing, or a special test for ligamentum teres involvement. This too is a symptom provocation test. The group of O'Donnell and colleagues reported a negative predictive value of 91% and a positive predictive value of 84%. The test is performed by flexing the hip to approximately 70 degrees of flexion, 30 degrees short of the patient's available full abduction. The examiner then passively internally and externally rotates the hip to end range looking for the patient to report symptom provocation at end range of either rotational motion. O'Donnell's group correlated this with findings under arthroscopy. It's important to note, the ligament teres is an evolving topic in the orthopedic and the sports and orthopedic literature. Remains an elusive diagnosis. However, we were able to make this recommendation based on the available literature for this particular CPG. In terms of making a recommendation for instability, we did not reach a threshold to make a formal recommendation. But what we do note is there are a number of tests out there that are described in the literature to assist clinicians in making the diagnosis for instability. Most of these tests, biomechanically speaking, are attempting to elicit symptoms by applying an anteriorly directed force at the femoral head in the acetabulum, therefore representing anterior instability. All these tests also, and we'll talk about the variations here shortly, again, try to incorporate, they're all symptom-provoking tests, right? So the tester, the examiner, applies this manually directed force, looking for the individual being tested, the patient, to report the symptom. So if you do look at this in the literature, limited literature that is available, we didn't make a formal recommendation. The top images that you will see are very different variations of tests: a prone position test, a supine, almost looks like a Thomas test, where the individual is then extended and externally rotated. I will show in this next video, we will look at here in a second, a sideline version of the test. Okay, what the examiner does is passively extends and externally rotates the patient's hip, and you will notice, in this case, it's my right hand, I'm applying a short or a small magnitude, relatively quick, anteriorly directed force in the posterior of the femur in an attempt to translate the femoral head anteriorly. There's safety considerations for this test. So again, remember that we suspect this individual may be unstable. So one, it's not going to be comfortable. Two, we do want to make sure that we aren't compromising them from a anatomical perspective. So that anteriorly directed force, though there is a velocity associated with it, that small magnitude is important, right? We're looking for symptom provocation, but we're not trying to make them excessively more irritable or potentially risk harming them. Okay, so again, that small magnitude, even with the speed involved, that small magnitude of movement while stabilizing the limb, maintaining a safe environment, is important for this particular maneuver. And whether you do this or, even though I don't have videos, either of the top images, again, we're looking for symptom reproduction. That may have some pain involved, but really, if you think of the instability presentation, there's probably a more important finding is if they're apprehensive. Also important to note with that test, it is not specific to, for example, dysplasia or the term microinstability, which is a term that encompasses soft tissue restraints being compromised with or without bony variations and resulting symptoms and functional limitations. None of those tests are specific to or that specific regarding the diagnosis. They just represent an instability presentation. In regard to patient reported outcome measures, in 2014, we were able to give an A recommendation for what many people call the legacy patient-reported outcome measures. Many of these have evolved through surgical literature. They're applicable to our patients as well. But due to that, you kind of had an early recommendation that was fairly high or strong, and that continues. So the numerous PROMs that are out there, the hip outcome tool or the IHOT, the International Hip Outcome Tool, the Copenhagen Hip and Groin Outcome Score, the HAGOS, the Hip Outcome Score, HOS, there's an ADL and sports-related subscale. Our recommendation is to use these to quantify, attempt to quantify or get a capture patients' functioning, including at a higher level or sports-related activity at the initial and then at least one other point and at discharge for an episode of care. a little more detail. The Hagos application has also undergone testing in the extra-articular groin pain population. So if you have an individual who has both, for example, FAIS, and maybe, I'm just using another example, an adductor or extra-articular issue of the hip and groin region, the Hagos may have a specific application to those patients. Also important to note, if as you're going through your evaluation, you begin to suspect that this may become this is more of an arthritic case, and though we're not discussing that in great detail here, we know that there's an established body of literature that describes PRMs for those individuals as well, in case you have to switch gears, as you go through your evaluation. New to this CPG and with a C-level recommendation are patient-reported outcome measures to assess for depression, anxiety, low self-efficacy, and kinesiophobia, with a similar recommendation at baseline and one other point, including discharge, for individuals with non-arthritic hip joint pain. And this recommendation is derived from fairly, at least since our last CPG publication in 2014, new evidence to show that these individuals do exhibit some of these characteristics. Many of these individuals do. So Inklinski and Benjamin in 2019 provided evidence showing higher preoperative incidence of anxiety and depression comorbidities in people with FAIS versus those who are undergoing ACL and shoulder surgery procedures. Joachimson continues to produce literature showing depression, anxiety, low self-efficacy, and high kinesiophobia associated with greater hip pain and worse function, specific to the FAIS population. So this evolving literature now shows now we can now make a recommendation that that we should look at these characteristics because they can have they may affect your intervention choices and affect the ultimate outcome of treatment for these individuals. Impairment assessment probably should go without saying, and it's good that we are actually going to make a B-level recommendation here, because this impairment assessment of all the things we talked about for evaluation probably drives our intervention, right? These are the things that we do. So we gave a B-level recommendation based on the available literature that clinicians should continue to assess impairments of body function. This includes reproducible measures for mobility, muscle strength, movement coordination, specifically perform measurements for range of motion, of internal and external rotation, flexion, extension, abduction, adduction. Again, not just an initial evaluation exam, not just an initial assessment, but also follow-up assessment to know if we are making improvement and to guide our intervention changes. Specifically, range of motion may give us information on femoral version, right? We know those individuals who are anaverted, and we do speak to this in the CPG. Individuals with anaversion may have significantly greater internal rotation versus external rotation, or the reverse. If it's a retroverted hip or hips, external rotation being significantly greater than internal rotation, as shown on the right-hand diagram. And this should speak to the Craig's test that is often described in the literature. Again, we do know anaversion, retroversion, we aren't using those specifically as always, at least as pathoanatomical terms, but they may be part of the clinical picture, overall. Microinstability, I spoke briefly to this. Again, this speaks to, and it's not a completely agreed upon term, but the presence of laxity, if you will, or excessive range of motion paired with symptoms driven by compromise or the soft tissue restraints being affected, so capsule, ligaments, etc., may or may not be in the presence of dysplasia or other bony abnormalities, even femoroacetabular impingement. However, the definition is not fully agreed upon, but in a consensus statement, Condusia and colleagues, as part of the Delphi study for this, agreed that 60 degrees of external rotation or internal rotation may represent microinstability. More recently, Curtis and colleagues noted an arc, right? So total hip flexion arc, when you added a hip flexion and rotation of greater than 200 degrees, also was correlated with microinstability. Important to note, again, with microinstability, not an agreed upon term. It's an emerging topic in the literature, but it represents the soft tissue constraints being affected and symptoms associated with that. Degenerative changes. As we noted, at times, you may change course throughout treatment if you start to what appeared initially to be a non-arthritic hip joint pain patient now is starting to you at least have some suspicion of arthritis being the concern. The Available CPG by Sabalco et al. And currently in revision. Recommend internal rotation less than 24 degrees or internal rotation of flexion 15 degrees less than the non-painful side if it's unilateral involvement, may indicate degenerative changes. So it's, again, sometimes you may change course if you start to see some of these findings come out in your evaluation. And of course, it's always important to note that we correlate these range of motion findings and strength findings we're about to discuss with symptoms, mechanism, other factors such as age, to get the big picture. Physical performance measures, there are a number that have now been validated in the non-arthritic hip joint population. You will notice that most of these tests, and all the few that we'll discuss are shown here, involve single leg performance. Right? So, and we know this is a pretty good starting point for functional assessment. If you're treating the athletic population, obviously at some point you will have to move beyond this to test that some that don't have as larger body of literature to support them, but we do realize there's limitations. However, as a starting point, single leg tests are probably where the greatest amount and quality of literature lie. Malloy and colleagues noted that these movement deficits that we see that are prominent that we see with individuals, and a lot of this is the femoral acetabular impingement syndrome. Not that we don't see them with double leg squatting, DLS, but in single leg squat and single leg testing in general, they become much more prominent. Okay. So as you look at the images in this slide, you will see the single leg squat test. Okay. I don't have the step down test here in this particular slide, but that is also been described in the literature. And the star excursion balance test. For all of these, the deficits that we see. So in the single leg squat test, we may see, which this is commonly described in other lower extremity literature as well, the valgus collapse, drop of the pelvis to the opposite side of the stance leg, internal rotation, right, adduction of that leg. You may also see, if you look from the side in the sagittal plane, premature or excessive anterior rotation of the pelvis as they descend. Okay. Of course, you would like to see if these correlate with symptoms as well, and compared if there is a non-involved side to the non-involved side. For the star excursion balance test, numerous publications have looked at this in this population. Again, we say non-arthritic joint pain, but most of these individuals were FAIS patients. The posterior medial and posterior lateral directions have been correlated with symptom and pain intensity PRS subscales, and this is the Hagos in this particular case. Those two directions, posterior medial, posterior lateral, have been correlated with symptom and pain intensity in those subscales, okay, for the Hagos. Now, again, we noticed that this is a good starting point. At times, we need more demanding tests. And so while we don't have substantial literature to guide individuals specific to the non-arthritic hip joint pain population, we did produce a publication that through Delphi, it's a consensus study through the Delphi method that made recommendations of tests that are known in the literature for lower extremity in general, and a rationale for progressing to more involved tests or less involved tests. Again, these tests in this particular, as referenced here, particular consensus paper, considered intensity, the criteria involved for the test, what you are looking at, what you need to consider, and then an example of each test. So we see low intensity, medium, high, and sport specific, or often clinician and patient selected, and you can see the criteria. A number of the tests that we just discussed are included here, but we added additional tests so that you have just a greater amount of options available. But we do realize too that some of these tests have much more robust literature to support them in this population, some not. Some are more based on a clinical rationale where gaps in the literature currently exist. Perspective for practice, these are published in the Journal of Orthopedic and Sports Physical Therapy. They're based on the clinical practice guidelines, the idea of the perspectives for practice, as shown here for this particular CPG, are to help summarize, almost in an algorithmic type fashion, the CPG findings to guide clinicians in practice. Now, this is somewhat expansive here. We didn't discuss all this, but initially there's a screening process. Diagnose and classify. Are we looking at do we believe we are looking at someone with non-arthritic hip joint pain, or is it another diagnosis outside that domain, which either we may or may not evaluate, or the appropriate at all physical therapist management? That's the initial kind of screening approach, kind of funnel-like approach. If we do determine that we are we think we are looking at somebody or evaluating somebody with an arthritic joint pain, then how is this particular condition affecting that individual? So we get their physical impairment measurements. These are things that we treat, so we have to assess them. We also reevaluate them along the way to note if we're making progress. How does the patient report that they are affected by this? And as we noted in the previous slides, not only their reported hip function per se through legacy measures, but also we should consider psychosocial components as well, depression, anxiety, low efficacy, because the literature notes that these individuals may have issues in this domain. Physical performance measures. How does it affect their quality of movement? What do we see in tests that are available in the literature? And as I've noted, we try to fill in the gaps too, so that you have a number of options that where those gaps do exist. We did note specifically, we have to determine irritability of the patient as they present, because that may, in the end, the intervention strategies, though not the topic of this particular video, will depend on that level of irritability, and you may have to adjust accordingly, right? That's the clinical reality of the patient in front of you. And then as we didn't discuss, but for sake of completeness, we choose an intervention strategy, and we do note the recommendations as you see in the lower part of this diagram here. But those strategies are based upon your diagnosis and your classification, your measures of outcomes, your irritability or your assessment of irritability, right? And again, you can see in the obviously provided in the CPG document the intervention strategies that we list here. And of course, reevaluation, always important. Everything you see above may change periodically. So consistent reevaluation, not just at the beginning and the end, but what happens in between, will help adjust your treatment or intervention strategy throughout the rehabilitation episode. So is the hip involved? Level 1. How does this influence the patient? How does this influence the patient? And to what extent are they affected? And then what treatment strategies are indicated? Again, it's always an evolving process. Oh, these are my references. Full presentation. It's very brief, but to summarize and also help to apply the recommendations for clinical evaluation of individuals with non-arthritic hip joint pain. My name is Keelan Enseki, and I appreciate you taking the time to listen to this.